Good afternoon and good morning. My name is Brian Smedley. I'm Chief of Psychology in the Public Interest at the American Psychological Association and also Interim Chief Diversity Officer. Welcome to Invisible No More, Psychology, American Indians, Alaska Natives, and COVID-19. We thank you for joining this webinar, which is part of a series that we're doing at the American Psychological Association connected to our Equity Flattens the Curve initiative. We're all aware of the devastating impact of the COVID-19 pandemic on many communities, particularly communities of color. But it's also true that other communities have been made vulnerable in this time, including older adults, people with disabilities, and many others. At the American Psychological Association, we're working to ensure that psychological science informs how we respond to the pandemic and many other societal challenges. And as the name Equity Flattens the Curve implies, we're trying to uplift and center the need to have an equitable pandemic response for all populations. The basic notion is that if we leave some communities behind, we all remain at risk during this time of pandemic spread. And so certainly the needs of many of our communities need to be addressed and prioritized at all levels of government and by leaders in many different sectors and levels. The American Indian and Alaska Native community has been particularly hard hit by the COVID-19 pandemic, but we know this only because of very sparse reports coming from some tribal governments and from some state and local entities, and news media reports have not fully covered the devastating impact of COVID-19 in the American Indian and Alaska Native community. This pandemic has resulted in things like restrictions in travel, limited access to needed services, social isolation that restricts normal support systems and disrupts traditional practices, and the resurgence of overt expressions of racism and intolerance have increased stress and social division at a time when communities need to come together in solidarity. And this is why we've launched the Equity Flattens the Curve initiative. This initiative has four goals. One is to center and to bring together the voices of those advocating for the needs of communities that are vulnerable and made marginal during this period, including communities of color. We also seek to disrupt the voices of hate and the resurgence in expressions of intolerance, whether it be xenophobic and racist attacks against Asian Americans or the resurgence of racist expressions against Black, Brown, and Native communities. Third, we seek to ensure that we apply psychology so that we can build more cohesive, inclusive, and equitable communities. We know from a large body of research that communities that are characterized by high levels of collective efficacy will fare better during the pandemic than those characterized by distrust and division. And finally, we seek to ensure that our policy response is commensurate with the devastation of the pandemic. We need to ensure that federal and state safety net programs, for example, address the basic needs of our communities, such as access to nutritious foods and housing assistance, as well as unemployment insurance for those that have lost their jobs. But we also need to ensure that we have a much more robust and better data collection and reporting system to ensure that we understand where the epidemic is going and which communities need assistance. And this is particularly true, again, for many American Indian and Alaska Native communities. I'm very grateful to Dr. Iva Graywolf for helping us to come to the realization that there's so much work that we need to do to make visible what has been invisible for too long, some of the challenges and concerns for Native communities. One webinar alone is not going to make the invisible visible, but it's a start. And we intend to do much more programming to ensure that even in the absence of the data that we need, that we're highlighting the challenges, needs, and concerns, as well as sources of strength and resilience in Native communities to help combat the pandemic spread. I'm thrilled to be joined by a very distinguished panel, and I'm going to introduce them shortly. Our panelists will each speak to work that they're doing in their communities. We know that many people will have questions during the presentations. We encourage you to enter your questions into the question box that appears to the right in your GoToWebinar screen. So not the chat box, but the questions box. And you can enter your questions at any point when the presentations are done. I will turn to that question box and pose questions to our distinguished panelists. So I thank our panelists in advance for their participation. I'm going to go ahead and introduce them. First is Dr. John Gonzalez. He is Ojibwe from the White Earth Anishinaabe Nation and a professor of psychology at Bemidji State University, where he also received his undergraduate degree in psychology. He received his doctorate in clinical psychology from the University of North Dakota through the support of the Indians into Psychology Doctoral Education Program. He's also a school board member for Bemidji area schools. Dr. Gonzalez's professional interests are in cultural psychology, which attempts to understand people as cultural beings through their own indigenous psychological perspectives, multicultural psychology, which takes into account the people's cultural, historical, and social political context, and community psychology, which actively works to enhance the strengths and quality of life in communities. Next will be Dr. Kyle Hill. He is Ojibwe, Dakota, and Lakota, an enrolled citizen of the Turtle Mountain Band of Chippewa in North Dakota, descendant of the Sisseton, Wahpeton, Oyate, and Cheyenne River Sioux tribal nations. Dr. Hill is a licensed clinical psychologist in the state of Minnesota, graduating with his PhD in clinical psychology in 2013 from the University of North Dakota. Dr. Hill recently completed a Master of Public Health degree at the Bloomberg School of Public Health at the Johns Hopkins University. And he is currently completing his service obligation as a Section 437 Indian Health Service Scholar at the Indian Health Board of Minneapolis, serving as clinical training director of an APA accredited doctoral internship program and APPIC accredited postdoctoral program. Next will be Dr. Vicki Lomé. Dr. Lomé is a Diné psychologist from Arizona. She specializes in providing psychological services to American Indian communities. For over 2 decades, she has focused on developing and interweaving culturally appropriate methods into her direct clinical work, including assessments, evaluations, and individual psychotherapy. Dr. Lomé's professional contributions include published works on developing and understanding cultural competency in neuropsychological and neurorehabilitation settings, and understanding indigenous perspectives of hallucinations, visions, and dreams. Finally, we're joined by Dr. Roylene Ross. She is from the Pueblo of Laguna, village of Poway in New Mexico. She received her PhD in clinical psychology from the University of North Dakota as a member of the Indians into Psychology Doctoral Education Program. She currently serves the rural and remote Alaska Native population as a behavioral health provider. Currently, Dr. Ross serves as the secretary of the Society of Indian Psychologists and is an active member of APA Division 35, Section 6, which is Indigenous Women, and Division 45 and Division 18. Dr. Ross is currently working on a book on child maltreatment written from an Indigenous perspective and other projects related to the intersectionality between mental health and law enforcement in Indian country, attributed in part to her former career experience as an FBI agent and New Mexico State policeman. Her professional interests include policy development, social justice, advocacy at the tribal and federal levels, and the advancement of mental health for Indigenous people. We'll go ahead and start with Dr. Gonzalez. And again, please enter your questions into the question box, and we'll pose those after all of our speakers have finished presenting. Dr. Gonzalez.
All right, Bonjour, Anishinaabe Dug, Makade Maingan Indigenous Cause, Gawa Babi Ganekag and Donchaba. First, I just want to say that I'm really honored and happy to be asked to be a part of this and share a little bit about sort of what I'm doing, or at least what's happening in my community here. So, as introduced, I'm a professor of psychology here at Bemidji State University, which is in northern Minnesota. Bemidji is located in the middle of 3 of the largest Indian reservations in Minnesota. We have White Earth, my reservation, my community, which is just to the southwest of us, Red Lake, Reservation, which is just north of us, and then the Leech Lake Reservation, which is just east of us. They're all within about a 15 to 30-minute drive of Bemidji. So we have a substantial native population up here. One of the things that I wanted to kind of just quickly, share, and then others, can relate to this as well too, is that, many folks don't know this, but American Indians experience some of the largest health disparities in the nation across all of the preventable diseases. And that is certainly true here in Minnesota as it is across the nation. We're more likely to die from diabetes, from cancer, heart disease, and so on and so on and so forth. So, that because of, that health disparities and those conditions that we experience, it certainly puts us all at much more risk for complications and certainly death from COVID-19. What's happening across the nation is exacerbated and probably happening much more in our native communities around the nation. And there's variability, of course, that's happening across the nation with native nations and tribal nations, and we even see that right here in Minnesota. One of the things that I find really, really interesting is the histories and the political structures that are in place that allow native nations to either protect themselves or not protect themselves. So a quick example is that here in northern Minnesota, Red Lake Reservation is one of the only 2 closed reservations in the nation, and what that means really quickly is that they have control over their borders, basically. That all the land within the borders of the reservation belongs to the tribe still as a whole, right? So you can't live on the reservation unless you're native, basically, right? Where Leech Lake, White Earth, Bois Forte, Grand Portage, all of the other reservations in Minnesota are not like that, right? So because of that, they were actually quickly able to close their borders and set up checkpoints and not allow anybody into the reservation. And as a result of that, they've been able to protect themselves a lot from COVID-19, whereas Leech Lake and then my reservation, White Earth, and then the Ojibwe and Dakota reservations in Minnesota don't have that ability to do that. So those reservations are actually seeing higher numbers of COVID-19 as a result of that, because people are able to freely move through the reservation borders, which is not the case in Red Lake, right? And then, the other thing that's sort of on top of that, right, is that, these are, somewhat rural places. I mean, your I guess definition of rural can vary and is relative or whatever, but we're pretty rural, and we've been somewhat protected by this for the most part up until basically the middle of the summer. So just over the week, so Bemidji is a sort of a tourist area in the summertime, and we get lots of people who come from downstate. We're about 3.5 hours from Minneapolis and the Twin Cities area. So, we get a lot of people who come up here during the summertime and have cabins, and there's lots of fishing and all that up here. So, up until about a week or so before the 4th of July weekend, we only had about 20 cases in Beltrami County, which incorporates almost all of the Red Lake Reservation. And then just yesterday, actually just this morning, we have 83 cases. So the number of cases in the last week and a half in Beltrami County have basically quadrupled. And the same is true for both Mahnomen County and Becker counties, which is where White Earth Reservation is located, and then Itasca County and Cass County, which is where the Leech Lake Reservation. Those numbers have also doubled and tripled within the last 2 weeks. So as a result of more and more people coming up into this region, we are seeing an explosion of COVID-19 cases happening. I've actually had relatives who've contracted the disease. I know a few people are actually hospitalized right now, right here in Bemidji, Native people. I was just reading a report from the Minnesota Native News that said that, officially there's been 350 American Indian Minnesotans who've tested positive. But of course, we believe that those numbers are actually much higher than that for several reasons. One of them is that there's a majority of people who, well, not a majority, but a lot of people who, whether you're Native or not, who have symptoms or don't have symptoms and don't know it, so they don't go and get tested and so on. And then having access, because we live in a rural places, having access to tests for COVID-19 is also very limited. In fact, just the other day, Red Lake notified their band members that they're going to have free testing actually starting this week, or is it early next week, for members up there. And this is also happening down in Weather. So we're, because we're so rural and because we have limited resources, we're kind of behind the curve in some ways, even in our ability to just meet those basic needs and make sure that people are, finding the resources that they need and so on. So, I think that providing that context is really, really important for folks to be able to sort of understand just a little bit more about what is actually happening in Indian country and with our native populations around the country. So with that, I will turn it over to the next panelist, Miigwech.
Thank you so much, Dr. Gonzalez. Very, very powerful and striking, and certainly hope that that things are able to turn around with the dramatic increase in cases there. Next up is Dr. Hill.
Yeah, Miigwech, John. Bonjour, everyone. Manidugwi Wizins, Indigenous Cause, Makwan, Budem, Mikanak, Wajuan, Yadunjaba. My name is Kyle Hill. I'm a licensed psychologist and graduated the same program as John and also Roy Lean. Very happy to be here, honored to be asked to help with this. Right now, I'm the clinical training director at the Indian Health Board of Minneapolis, and this is really the urban center for at least Minnesota, if not, North Dakota, South Dakota. So we have a lot of natives from all of the surrounding reservations in the region. And so just to get started here, some basic notes. We know that 2/3 of Native people live in urban areas, upwards of like 70%, and what we find is that, for a lot of reasons, our populations in these urban areas are typically invisible in the sense that, like, phenotypically, there's no defining characteristics for Native people. And oftentimes, which is similar to Minneapolis, communities that were once kind of the areas of the Relocation Act, which was a federal act in like the 60s, they've been gentrified since then, so they've really broken apart. And so there's a changing demographics with the natives in South Minneapolis, in particular with gentrification. And so kind of following from the topic of this presentation being like invisible no more, I think one of the major points to hit is the fact that we see ourselves the eraser in data at the federal, state, and county levels, but also, like I said, just in everyday, like social systems, functions, really at every level. And so when I was asked to do this, I just wanted to give an idea of kind of, I guess, the scope of the problem that we're looking at. And Dr. Gonzalez did a really good job at kind of poignantly discussing some anecdotal evidence from up in northern Minnesota. But from just briefly from the CDC, we have age-adjusted hospitalization rates of 221.2 per 100,000 people as compared to 40.1 per 100,000 for non-Hispanic whites. So we're looking at more than 5 times the hospitalization rate for American Indians than that of non-Hispanic whites. So it's by far the highest rate of hospitalization for COVID-related diagnoses of any racial group collected by CDC. So following from that, I just looked at the Minnesota Department of Health. And so what I found was that the actual case rates, our incidence rate is very low. It's still higher than non-Hispanic whites. But to John's point, or Dr. Gonzalez's point, I think that's a drastic undercount because people either can't access healthcare, they don't know because they're asymptomatic, or they're just not getting tested because of an enduring mistrust for our health services and the infrastructure that are placed on reservations, communities in Minneapolis and in the state of Minnesota. And I'll talk a little bit about that later. But what I did find is that, one, kudos to Minnesota. Minnesota Department of Health at least published their data on American Indians. And what I found was that American Indians represent the highest percentage of positive cases hospitalized, ICU admittance for positive cases, and also those who have died from COVID-19 complications during this time. And so, you know, again, here we see that what John or Dr. Gonzalez talked about a bit before was that there's several health disparities and chronic conditions that intersect and that compound the threat of COVID-19 within both like urban and rural Native populations. And so what this kind of leads me to is to talk a bit about like the social and cultural political determinants of health. And I think that this is the underlying issue. And so what I like to think about this is it's essentially where we live, learn, earn money or work, eat, play, and pray, you know, if you will, for like this cultural determinants of health. But what I like to think about this is really like the enduring impact of settler colonialism here is what we're thinking about, because I mean, prior to COVID-19 and prior to the unrest in South Minneapolis with the murder of George Floyd, American Indians were experiencing like poorer educational attainment, higher unemployment rates, housing situations that were overcrowded and often multi-generational. So you had grandmother and matriarchs to households or communities or families that were living in the same household, you know, frequently with grandkids and great grandkids sometimes, and so large families. And I think really that's one of the biggest issues we're seeing right now. But in addition, more likely to rely on public transportation in the city, often living in densely populated areas without much green space or social distance space, and living in kind of food deserts, you know, not close to grocery stores or anywhere that they could find, you know, healthy food. And this is not something that's new. As I said before, this existed, you know, this has existed for a long time. But one interesting characteristic of natives, I think that's really beautiful, but also has been difficult to reckon with and reconcile in the face of COVID-19 is the fact that a lot of our people work in jobs that are essential, right? You're often, because that's all we see on the reservation or in the community, that's all that's available sometimes, whether that's, you know, jobs at the grocery stores, gas stations. You know, for me, I'm a healthcare worker. You grew up, you know, with those basic essential functions if you grew up on the reservation, or a lot of your community members or family members were already kind of in that area. So we're seeing that this is a big issue, you know, high unemployment. But if you are employed and gainfully employed, you're an essential worker, which presents a whole host of challenges in this time. So, and also to Dr. Gonzalez's point, we're balancing pre-existing conditions within our communities, you know, and the pandemic has only pushed infrastructure systems and community organizations to the edge, if not exceeded their capacities. So some of the general concerns to the community that I'm noticing and that I was kind of afraid of as this started was this idea, you know, the issues that we've dealt with as a people due to like colonization and due to you know, this ongoing like imperialism in our country is like this historical trauma that we carry, you know. So there's blood memory of pandemics and epidemics in the past, you know, and so historically disease was used as a weapon to really annihilate indigenous peoples from this land. And so now what we find is that there's a tremendous amount of fear and grief and anxiety over losing our elders and knowledge and oral history, you know, and this extends to spiritual healers and matriarchs, like I said, of the overcrowding and multi-generational households. And so clinically at work, what I've noticed is, of course, the chronic stress and often toxic stress, but also the increases in suicidal ideation, increases in substance use and relapse. You know, when a lot of people are in these systems that kind of continue to oppress us or are very difficult to reckon with, such as like child protection and stuff like that. This, you know, the compounding effect of COVID makes it all of this so difficult, you know, so difficult. People are afraid to leave their houses, and if they do, they have to exchange 2 or 3 buses just to get to anywhere they need to go. So in the Minneapolis community, you know, we see that there's limited access to healthcare, you know, or no access with the stay at home or stay safe order, and these beliefs or thoughts that they engender. You know, what happens if I go and present to the clinic? Are they not gonna take me? You know, and so local Native nonprofits here had to close and shift to remote work, right? But also public transportation was very limited during the early months of the pandemic. So, and this also, I think, one of the big things after the George Floyd murder and the resulting unrest or the uprising, you know, was that there's this really complicated the food insecurities that we see in the urban areas. Like, for example, like food shelves had decreased operations, there were shortages, transportation to grocery stores was limited, and a lot of these essential businesses in the Native community in South Minneapolis were actually burned down. And so there was a huge impact on the community members. But a good thing was that a lot of community members, organizations, because of the strength of the ties to the communities, really stood up and chipped in to restock some of these, and you know, volunteered time. A lot of people volunteered time to do this. And in addition, there was the economic impact, reduced hours, layoffs, time delays, and unemployment. And I think someone else will talk about this later, I think Dr. Lomé, but the ceremonies were canceled and paused, right? We have ceremonies each summer where I'm from, and it made it very stressful. And really, a lot of people have a hard time going into these very important ceremonies that their communities and families rely on to get them through each year. You know, and some of the saddest things that I've noticed is that elders and others are lacking in physical connection, right? They don't know why their family is neglecting them or not there right now, but it's essentially kind of the complexities of this time has really profoundly, I think, impacted our sense of beliefs and who we are as Native communities. So we see that people are upset or are saddened, and in fact, sometimes even, you know, feeling hopeless because we can't connect the way you know, the love doesn't look the same. Now love is, you know, you clean stuff off, or you clean stuff off before someone comes in your car, or you just don't see them, period. You have to wave at them from a different, you know, from your car while they're in their house or something. But finally, just to close, through all that, we've seen, you know, sources of strength, you know, the collective resilience of our communities, you know, coming together to assist in this urban community, whether it's protecting our own community and doing, you know, surveillance, not surveillance, but coming together to police our community because of the George Floyd murder and the unrest, right? But also to help community members delivering food to elders. And so at the same time, you know, it's been such a difficult time. There's also some very beautiful things happening in our communities. And, but the pressure that it's put on the fabric of our cultures and the fabric of our existence as collectivistic communities has made it difficult to really experience the strengths and protection from our culture and spirituality. So yeah, thank you, Miigwech.
Thank you so much, Dr. Hill. I want to encourage people to continue putting questions into the question box. We'll be able to get to these after our presentations. Next up is Dr. Lomé.
Fiat a she a Vicky Sinajini Lomé and she Nagani Nishlando Sinajini Bushichin she a see lay Beshagi de Nasha Arok Ade hostot a Shananisto Sharan. Greetings, friends, relatives, colleagues. My name is Vicky Lomé. I am a clinical psychologist, and I currently work in the Scottsdale area for the Salt River Indian community. I've also had experience working with the Phoenix Indian Medical Center, as well as the Tsahotsui Medical Center up on the Navajo Reservation. Some of the challenges that I have seen faced by the Indian communities, the Native communities, not only have I seen it in my clinical work, but also just from personal experience. I'm sure many of you have seen some of the media coverage with the regarding the pandemic and the Navajo Nation, and it certainly has touched home for myself. I continue to maintain ties to my traditional community. My family's still there. You know, I still go back quite a bit to see my family and to participate in ceremonies and things like that back home. And this has certainly, the pandemic has certainly been challenging. Some of the things that come to mind right off the bat are the stressors that are associated with just basic needs, meeting basic needs in Indian country. And in places that are rural and remote, this is definitely more present and more obvious. You know, access to you know, shelter, basic needs like water and utilities, access to food, reliable transportation, having a sense of safety, um, access to healthcare, and kind of in line with that idea of sense of safety is this sometimes not only overt racism, but covert racism as well. You know, as far as you know, shelter, as had mentioned before, there are access to available housing can be difficult in certain communities, and especially in some rural and remote communities that there are often multiple generations living in the same household. So when there have been these recommendations and like the CDC guidelines to you know, maintain physical distancing, you know, keeping in mind, you know, certain age groups such as elderly folks or health compromised, you know, of maintaining some physical distance from them. You know, it's often difficult when there are multiple generations living in the same home. Um, and as far as, you know, access to basic utilities, it may be difficult to believe this, but in some places there is still no electricity. There is still no running water. So when we are told to do frequent hand washing, you know, wash everything down, wipe everything down, you know, when I am trying to ration 12 gallons of water, it becomes difficult. When, you know, if someone in the household tests positive and, you know, they need to, you know, some of the suggestions are to make sure that they have their own bathroom or that they have their own bedroom. Again, these housing issues, and again, basic utility issues come to mind, is that, you know, sometimes it's just not possible. And a lot of times it's not an easy fix to get these basic utilities. You know, it can be a very expensive undertaking for a family to try to get some of these basic utilities that many people take for granted. I'm sure many of you can just, you know, walk right down into your kitchens and, you know, turn on the faucet. But, you know, when you have to drive 12, 14, 25, 50 miles to haul, you know, so many gallons of water, you know, it becomes difficult. One of the other things of access to food, especially in some of these rural and remote communities, is also, again, having that reliable transportation. Public transportation may not be available at all, and especially with some of the medical transportation or other transportation that sometimes are provided for communities with the pandemic, some of those services have been shut down. So how do people without transportation, how do they go get food? Again, also with the same with access to healthcare. If the clinic is 70 miles away and there is no reliable transportation, how is someone going to get access to healthcare? One of the things that I had mentioned earlier was, again, some of this covert and overt racism. I have definitely seen this, especially, in my community where at one point, the positive rates for COVID-19 were skyrocketing on my reservation, and some of the border communities, border towns, were getting quite vocal about having community members come into town for fear of transmitting the virus somehow. So definitely some very not so nice things being said. One of the other stressors, like Dr. Hill had mentioned, was just not accessing, not being able to participate in ceremonies. In my community, summertime is one of the times that we participate in certain ceremonies that can only be done at this time of the year. When we can no longer do those, it certainly adds another layer of stress. Ceremonies are meant to traditional methods to combat stress or to heal or to provide community support, to provide those healing methods that we traditionally relied on. And when we cannot gather to do those things, it certainly does add another layer of stress. One of the things that I think is clear is that how the tribes across the nation are handling the pandemic and the response varies actually widely. There are some tribes that are able to provide a lot of support while others are continuing to struggle. There are some, as Dr. Gonzalez had mentioned, of being able to close their borders completely in an attempt to control how the pandemic is affecting their community, while others don't have that ability. But I think also, as far as again, accessing healthcare, which communities and tribal communities do have clinics or hospitals, and which places have to rely on urban Indian centers or centers off of their communities. I think one thing to remember, which Dr. Hill had also mentioned, is that a lot of these communities, and what I have seen, not only personally, but just in these communities, is just how resilient tribal people are. I have seen so much creativity and community involvement with how some people are stepping up to help those who may not have access to water or who may not have access to groceries, and certainly a lot of grassroots efforts going into developing creative ways to maintain social connections, maintain, again, basic, making sure everyone has their basic needs met. So definitely a lot of resiliency. And again, this is a topic that we, the time that we have allowed to us for the short period of time is definitely not adequate. Please feel free to drop some questions in the sidebar, and I will pass this on to Dr. Ross.
Thank you so much, Dr. Ross.
My name is Roylene Ross. I am from one of the Pueblo tribes in New Mexico and currently serve. The majority of my clients are Alaska Natives here in Nome, Alaska. And so I am 1 or 2 miles from home. I wanted to extend my appreciation, as I am very honored to be here today. So as you have been informed by Drs. Gonzalez, Hill, and Romay, the effects of the COVID-19 pandemic have affected the tribes in different ways. In consideration of the 574 tribes in the United States, each individual tribe has been affected differently, in the same in some ways, but very differently in others. As Dr. Gonzalez said, many tribes have decided to close their borders for the protection of their people, exemplifying the tenets of self-determination and ethnic leadership. Some tribes have elected to mandate and enforce stricter guidelines than states have implemented for the communal ethic of care. But also in consideration of that, there may also be feelings of amplification of historical trauma due to the pandemic as well. So yesterday afternoon, I returned from an Alaska Native village called Little Diomede, which is about 2.5 miles from the Russian international border. In this region, there have been travel restrictions, which into Nome requires a travel permit. They may or may not have lifted that, but all of that paperwork had to be filled out to even come into Nome, which is considered a hub in the northwest region of Alaska. There are 15 Alaska Native villages, and each village has their own travel restrictions. The populations in the villages range from 80 to 750 residents, and each village, as I stated, has different quarantine guidelines, COVID testing guidelines, and social distancing, is a commonality amongst all of them. Definitely shelter-in-place orders have made access to services more difficult to access, and social isolation also restricts normal support systems, as both Dr. Hill and Dr. Romay have alluded to. In the villages in this region, most rely on paraprofessional community health aides who are also experiencing increased pressure and stress due to the COVID spreading in this region. Currently, there are under 20 positive cases, with 3/4 of those recovering and some active. Where I'm from in New Mexico, I have been informed that there are also less than 20, and it's been contained in my tribe. So again, going back to each tribe having different experiences. In this region in Alaska, the pandemic has brought about some of those historical traumas related to tuberculosis and the Spanish flu, which occurred here between 1918 and 1920. Some of the villages here, the death rate was between 50 and 60%, while in others it was as high as 90%. The pandemic in the early 20th century created the foundation for orphanages and the placement of Native children across the state. So that historical information is very real today in how the Alaska Native tribes have responded, but also the tribes around the country as they have closed their borders. With regard to transportation, as Dr. Romay talked about, in the state of Alaska, the majority of travel is by air, as there are no road systems out of many communities. In Nome, there is a road which leads to one of the villages, or two of the villages, but otherwise travel is by air, by helicopter, or by some of the smaller planes. That has been disrupted, air travel has been disrupted because one of the local airlines serving this region went bankrupt. So some of those cargo flights, cargo deliveries, and supply flights have been cut off, and some of the regions have not had that access to incoming supplies. Thus, subsistence, the reliance on subsistence living for many Alaska Native families has increased. Fishing, right now the salmon runs are occurring, hunting, the different game in the area, but this is also the livelihood for survival for many of these families in the area, because Alaska, many regions of the areas of Alaska that are remote are considered food deserts. So that food, getting the food in, is very important. Fortunately, getting the food in from Alaska or from Anchorage to the hub is that much more important during this pandemic. There's also that difficulty in accessing typical medical care without the pandemic, so that increase in services and or need for the different villages has also created some interesting situations for individuals who've needed to go out or get medevaced out. That has not precluded services, it's just created a few more navigation of the medical system. One consideration that I wanted to mention was about the education system across the U.S. for Native students. And of course, that encompasses Bureau of Indian Education schools, that encompasses public school systems, that encompasses, there are still some boarding schools in the United States. But while many school systems shut down and those students were able to obtain Chromebooks for their, online school activities, and those school districts ensured that educational standards were met for those students, many Native students fell through the cracks, especially those residing in rural and remote communities. What that means is that in March, when the shelter-in-place orders were disseminated, many school systems were not able to serve the remote areas, and many Native kids have not had any educational courses since then. So that has implications in and creating a greater disparity for those Native students. The question, may be raised that, well, how will this skew the outcomes of psychological evaluations by school psychologists and others when assessing grade level abilities? That may be, the outcome for many of these Native students who have not had access to education. In addition, there's this myth that Native people receive monthly checks from the government, which is untrue. Unemployment in many tribal communities is high. The pandemic has increased that or contributed to higher unemployment, especially as it pertains to gaming and the tribes that have gaming revenues coming in as a part of their overall services that they provide to their community members. But in addition, that has also had an impact on employment for other non-Native individuals because they are also out of work. So in all, these conditions that I talked about, definitely increase stress, anxiety, depression, and will manifest themselves psychologically in other ways. But I also want to highlight, as Dr. Hill and Dr. Lomé alluded to, that the Native population is resilient, and leave that as my last thought. I'll turn it back over to you, Dr. Smedley.
Thank you so much, Dr. Ross. I want to thank all of our panelists, Dr. Gonzalez, Dr. Hill, Dr. Lomé and Dr. Ross. And I'm going to stop screen share so that we can allow each other to be seen. We have received an overwhelming number of questions for which I'm very grateful. It shows a lot of interest in what people can do. And one of the common questions that we're receiving is, what can people do? What can psychologists do? And in particular, what can non-native psychologists do to help? I'll turn that over to any of our panelists.
You know, what I would suggest, and as far as what you can do to help, I think just in general is educating yourself on the Native communities in your area. I think finding out more on your own of what communities were there, what tribes were there, and who still remains, and what is going on in your community. That would be one suggestion that I would make.
Yeah, I would just, agree with that completely. I mean, that's usually the first, well, I mean, the first step is figure out who you are and knowing who you are as an individual and what you are, as a non-native person, whether you be white or any other racial group or ethnic group, is, you got to understand yourself. But then, like Dr. Lomé said, is, you really need to sort of take some initiative on your own to find out whose land that you're living on, right? Who were the tribes that were there before you or who are still there and so on. And, really sort of having an understanding of that in the history and the context is important. And then, reaching out and, connecting with other Native folks who are doing this work and within their communities and so on, whether they be professional or non-professional, right? The community leaders and so on, and trying to make those genuine connections. Those things are, paramount before because we don't need no more saviors. I'm just going to put it out there. We've been down that road before and it hasn't worked. So.
Yeah, and I would just piggyback off that. I mean, I can't say it any better, but advocacy for lines of education programs, funding. We have an internship program, but we need more internship programs that are staffed by American Indian Indigenous psychologists, helping break down the barriers to entry that we see in our field and certainly in other fields. Some of the costs that we find to get licensed, to renew licenses, to get the EPPP, I think those are pieces that are very real and profound barriers to getting in, but I think what I find most pressing as an issue for those of us who really adhere to a strong traditional culture and spirituality is to allow workplaces to honor those on an annual basis, to get people to really be able to employ their strengths every year. I rarely ever see that we have leave for religious and spiritual leave when other communities have a leave that we call a weekend every Sunday. And right now it's really pressing our communities to not be able to engage in these ways, their spirituality and traditions and traditional ceremonies. And sometimes those ceremonies are just, gathering food from the reservations or gathering medicines, from our reservations. But we need advocacy, to exist. We need advocacy to be, we need advocacy and relevance. And I think that once you understand your role as an ally, you do the education that's necessary, then you're in a place to advocate strongly and support us in a very real way.
I would also suggest and emphasize a cultural humility approach and not making assumptions about a person's experience in the session. Asking that person, what is your experience? And because of these circumstances that have been brought up, to assume that an individual has running water or electricity, that's a big assumption. And so meeting that person where they're at, taking Western psychology, and instead of having that person meeting you with that background, you as the provider meet them.
Thank you so much. Again, we're receiving many, many more questions than we have time to answer. I apologize for that, but very grateful for the high level of interest that that our listeners are showing. Another question that seems to be a common theme. Maria writes, I appreciate Dr. Hill bringing up the critical role of our elders and the complexities of honoring them in traditional ways and also protecting them. I would love to hear the panel speak more to this topic of elders and COVID-19, especially given this pivotal time in history of intergenerational knowledge being passed down. So while this is directed to Dr. Hill, I open this for any of our panelists.
Yeah, I think definitely elders are highly respected in many of our communities. And yes, it is definitely difficult, as Dr. Hill and everyone else said, about the social isolation is difficult. My own mother is 82 years old, and she should be out, socializing at ceremonies and being with other elders, and she's not. So yeah.
Yeah, I mean, let me just real quick. I mean, it is really a serious, big issue. I mean, again, most people respect their elders and so on and so forth, right? But for the Native community, I mean, they are our backbone, right, of our communities and of our nations, and with all the knowledge and so on. And it's really, really scary. I mean, it really, really is scary in terms of how and what we can do to protect them. I mean, I shared this with my colleagues here, whatever, but my brother-in-law died from COVID-19 about a week and a half ago, and he was from Mille Lacs, which is closer to the cities than I am, and he was in his 70s, so he's a bit older than I am and so on, but he was, he's known in some circles as the grand master of moccasin game here in Minnesota. So some folks might know who I'm talking about there, but he had this abundance of knowledge about moccasin game and what that meant to the Native community, Ojibwe people and Lakota people in particular, and was always doing that and sharing that or whatever. And we've lost that. We just lost that, and that's the scary thing that's happening. And that we want to protect our elders, but yet we don't want to we want to connect with them, and they need that connection and so on. So it's a scary time.
Yeah, and I think just briefly, I think, Dr. Gonzalez hit it on the head. I mean, that's all of who we are and aspire to be is hanging in the balance, and it's sad and unfortunate to see the, government and federal officials trying to undermine, certainly the data that we're trying to represent in a very transparent way, with the hospitals trying to send data to the CDC that's now going to the Health and Human Services. But I think another aspect of that's difficult is that they're not being able to be seen for the other conditions, because we obviously, like Dr. Gonzalez pointed out, there's a high level of comorbidities in our population. We have diabetes and depression. We have, heart disease and anxiety. We have issues with the liver cancers. We have issues with, so I mean, it's just a really, that's the biggest threat, and that's super, really sad. And so we just pray, it's the best thing we could do.
Thank you so much. I want to thank our panelists. This has been just superb. It's heartrending, and it's also very powerful. So I thank you for sharing your knowledge, your expertise. To everyone on this call, this can't be the last conversation. This is just the beginning of many conversations that we hope to have as the American Psychological Association stands in solidarity with our Native communities. We're going to be doing more advocacy to address the needs of our communities. So we invite you all to join Equity Flattens the Curve. You can join the conversation on Twitter at #EquityFlattensTheCurve, or you can go to the American Psychological Association's website at apa.org, We have a COVID-19 resource page. If you go to that page and then click on the Bias, Discrimination, and Equity Resources, you'll see information about other activities related to Equity Flattens the Curve, as well as where to sign up for hashtag Equity Flattens the Curve. Again, I want to thank our panelists, Dr. Gonzalez, Dr. Hill, Dr. Lomé, and Dr. Ross. Thank you so much. I hope to remain engaged with you as we work together to address some of these challenges. Thank you all for participating.
Miigwech, Nagaj.
Which